to moderate with my friend and colleague, the Professor Isaac. I remember the first time I knew I met him was on during a fellowship by NCOBC, and we were in the US, and he shared what he did in cancer in Nigeria, and at the same time I was talking about what I do here in Senegal, and since there we are working together. Welcome to everybody. It's an opportunity at this time, at the end of the pink months, to share what we know here in the West African region, and about like in whole Africa, and the state of the art, and what where we should go. And I welcome everybody, and at the same time I say thank you to AORTIC and the people who are all time, like Khadija and others, Khadija Osman and others, who all time are behind us and pushing to let us, or to permit us to do better. Thank you very much, Isaac.
Yeah, thank you, Sidi. We will not waste much time. We have 4 speakers that will be spending about 10 minutes each, and they are all ready to go. And our first speaker is Dr. Fumilola Olanike Awurola, who is a fellow of West Africa College of Surgeons and has received several awards in her research in colorectal cancer. She has a master degree program. She has won a master. She has won a master. She has had a master. She has finished her master in surgical oncology, and she's also a certified genetic risk assessment scholar. So, without much ado, I want to invite Dr. Fumilola Olanike Wurola to give a talk. I'll stop sharing so that she can go ahead and share a slide.
Hello, everyone, and thank you for having me here today at the AORTIC. It's a pleasure to always be at AORTIC meetings. Today, I'll just be talking, sorry. Just a slight mixed up, sorry. I think I need to stop sharing that. I'm sharing it on slide, sorry. Yeah. Okay, so this is what I'll be sharing today. And I'm talking about the role of genetic testing in breast cancer management. And I'll be using the perspective from Sub-Saharan Africa. And just a means of introduction for all of us is that breast cancer accounts for about 5 to 7% of all breast cancers. And this is the data this is the data that is well known across the world, but then it has been shown that the percentages for hereditary breast cancer seems to differ from one location to the other. And a study that was done in Nigeria shows that we have a higher rate of hereditary breast cancer mutations compared to what is seen in the West. We have observed 7%. And Isabella, can you mute me? Thank you. Okay.
Yeah, please. If you are not speaking, kindly mute yourself. Bemira, can you help us mute those that are not talking, please?
Okay.
All right.
Thank you.
Go ahead for me.
Yes. So it shows that we have a slightly higher rate of hereditary breast cancer. Unfortunately, compared to other parts of the world where the number is smaller, we that seems to have a higher rate in the sub-Saharan African seems to have very limited access to testing and to counseling. And one thing we need to know is that for people that have a higher rate of mutation, especially in the actionable genes like PRCA1 and 2 gene, the lifetime risk of having breast cancer is significantly higher than the general population, and it could be as high as 70% in their lifetime. So this underscores the reason why we need to have genetic testing done. And who should be tested? There are different guidelines that is telling us about who should be tested. And recently, had a guideline from HASCO and Surgical Society of Oncology is trying to say that it looks like every woman that has breast cancer, on the real sense of it, should be tested because there's a significant number of people that are being left out by the present criteria. But the criteria that most people are more familiar with is the NCCN guideline, which says that there are a certain number of people that are likely going to be more positive. And since there's a way where we are rationing what you can do at a point in time, that the people that are likely going to benefit more from the testing are usually younger women. And I'm saying of women that are less than 60 years of age with breast cancer, women that have triple negative breast cancer, people that have multiple family history of breast cancer, or people that have previous breast cancer themselves, or other malignancies in them, and people that have they are Ashkenazic Jewish in origin are said to be people that should be tested. And anybody that comes with male breast cancer is advised to have genetic testing done. And if you look at this criteria critically, you see that majority of patients that we are seeing in this part of the world actually meets the criteria, because if you think about the age, good data coming from Africa show that we have a younger age at presentation. We're having more than 50% of our population presenting breast cancer, less than 50. Also, we have a higher number of people that have triple negative. We have like 40 something percent, 45, 46% of our patients having triple negative disease, which is at variant to what is seen in North America. So these further reinforce the need why our patients should be advocated for and where they should have genetic testing done. When you are trying to talk about the breast cancer risk by subtypes, there are so many risk, and it has been graded in different ways. We talk about the moderate risk, the high risk, that are actionable. But when you talk about people that have BRCA1 and 2 gene, the odds that they are likely going to be triple negative is higher compared to other people. So they have the odd of 4.4 range of having it. So it shows that this is something that needs to be tested. We need to test people, especially the triple negative patients. We are more of our own patients. And when you talk about what does this testing, what does it means for the patient themselves, and what does it mean to their relatives? So we should always remember that the testing alone is not it helps the patient in management, but at the same time is useful for their own relative too. And if you have anybody that has been tested, there are some genes that already are actionable. The BRCA1 and 2 is very actionable because there are things that can be done to reduce the risk. Preventive mastectomy has been recommended for people that have that. People that have PAB2, TP53 and all that. And also screening is recommended at a lower age for them, as that's been displayed on the screen. Meanwhile, people that have like ATM check too should have screening, but there is insufficient data to say whether they will benefit from preventive mastectomy, that is having prophylactic mastectomy done. When you are managing genetic risk, people have tried to compare the effectiveness of MRI, and it's safe for me to say that MRI is very effective, but at the same time, we need to think about other things associated with it, especially thinking about where we will operate, how many MRIs are available, how many radiologists are available to be focused on doing breast MRI alone. And again, the cost comes into play. But this is a very viable alternative for patients that does not want to have prophylactic mastectomy done, because studies have shown that it compares favorably. That is, by the time you do so many MRIs, you are likely going to detect a lesion early enough for you to intervene before it becomes a full-blown malignancy. And that is why it's a very important option. when you talk about managing genetic risk as in the use of preventive mastectomy, this study is showing us that people that had mastectomy done for PRC1 carrier or PRC2 carrier, their risk dropped significantly as in compared to people that did not have any form of intervention. And this is important because when somebody has a risk of 70% of having breast cancer in their lifetime, and you are able to reduce this risk significantly to 1 to 2%, I'm sure most people will prefer that option rather than having a breast cancer in their lifetime. Other roles that genetic testing can confer on patients themselves is the fact that the use of agents olaparib for patients that had the carrier of BRCA1 or 2 mutated breast cell, it has shown that it helps to increase the overall survival. And initially, this was more in the metastatic setting, but now it's been advocated in the adjuvant setting, even for a non-metastatic cases. And this will influence the kind of treatment you give patients. So that means for our patients that a carrier that we are not going a step forward to give them some of these drugs, we are already making them to lose out on something that can help them eventually. So I'm just going to give us a quick rundown of something we've been doing, and this is a new study that is going on in Nigeria at this point in time. And this is just to address the inequality that has been seen from genetic testing, like I've alluded to in the beginning, that we have more patients, but very few of them are being tested. And this is to develop a program that we feel that if this program works very well, it has ability to scale to other parts of sub-Saharan Africa because our problem seems to be similar. And this is that one of the things to do is to educate. And in our education, our aim is to develop a educational curriculum for healthcare workers. And one thing that we discovered is that before this study, there was already a need assessment that was done amongst the healthcare providers to see what are the challenges majorly to adopting this intervention. Also, we need to know that the number of genetic counselors that are available are limited. So if we have to test everybody, we have to find a way to step down this knowledge to the routine oncologists that are going to see them before they are sent to genetic counseling. And this is obtainable in other parts of the world, so where people are trying to step down because of the volume of people that needs to see genetic counselor, which are limited. So we also talk about patient education, which is the other aim, and how accessible, how visible is it for us to be having BRCA1 and 2 testing routinely before initiating treatment for an average Nigerian patient. And the first thing that we did, like I said, is the need assessment. And one of the things that we found from the need assessment is that very few number of people have ever had a formal training in genetics. And sorry. Okay. Sorry, very few people have ever had training in genetics. And another thing people talked about is that there's no genetic counseling services in their facility. And this is not only for breast cancer, even for all other diseases that need some form of genetic counseling, there is none that existed in their facilities. And the pathway for testing is actually limited. So which are the factors that we saw? But we felt that it was important for us to intervene at the level of the genetic counseling, which is something that is we can do within her. So what we did was to, with some other experts, we were able to start the online module. And this online module is to educate people on the basis. We limited it to just BRCA1 and 2 testing, and how do you inform patients, how do you, and we're very amazed at the number of applications that we had and the number of people that were trained eventually. So it was a hybrid training. We have both a online and an in-person training. These are part of the in-person people that care for the in-person training. And it shows that there's significant impact in knowledge, specifically for module 2 and module 4, which does more with the counseling and about how do you advise people on their risk and the prophylactic treatment that they are going to have. We also found that from the need assessment from the patient's perspective, very few patients is aware of genetic testing, and very few patients knows what to expect. And we felt that one of the things we could do is to improve the patient's education. So for every patient with breast cancer who falls into the criteria for testing, they handed over this patient education in their own language that they could understand. And this we also explain to them by a healthcare provider for them to have an idea of what happens. Assuming I have this gene, what do I do? What are the factors and how does it affect my overall treatment? And the third aim, which is something that has been a major issue before now, is how do we get to test people in real time? People have access to tests depending on where they are. Some people in a very high centers, which is not accessible to most patients, could afford to do this, but this is not what is done routinely in every clinic. So what this study at this point is doing is recruiting patients in real time, sending their sample. So we are collecting the saliva sample, and this is being tested. And for those that are positive, their treatment plan is following what should be done for people that are BRCA1 and 2 are tested positive. So this is an ongoing study and is making a real-time clinical decision. So this is just a schematic to tell you of how we collect sample and all that. And presently, we have reached 69% of our QRA, and the results that are back to us are showing that we have as high as 17% risk of having a genetic testing. This is significantly higher than what has been reported in other claims. And we think this is a good step for us to keep doing this and to see how do we help more patients going forward. And what are the challenges that we've been facing? We know one of the major challenges is that how do we get sites that will be domiciled in Africa that can help us to do this testing? Because before now, Invicta, which is one of the leading biotech companies, seems to have presence in Africa, but presently they don't support sample on a large scale from Africa. Also, we need to have companies around. We should leverage on COVID testing to start doing this for our people so that we don't have to keep sending samples all across the ocean before the result is out.
It's
And I think that
round up.
so future considerations, we think that this is something that should scale up to other part of the country. Presently is in 3 sites, but we think we should be able to scale out to other part of Africa going forward. And I want to thank everybody for listening. I'm available for questions. Thank you.
Thank you, Dr. Wurola.
Yeah.
The next speaker will be introduced by my co-moderator, Dr. Sidika. Please go ahead.
Yeah. Thank you very much, Isaac. And the next speaker will be the Dr. Melvin Akiaman, and he's a clinical oncologist at the Korlibu Teaching Hospital. He did a lot in variation and racial disparity in cancer response, genetic variation. So, and we will welcome him and listen to him. Dr. Mervin, you have 10 minutes to give us your presentation. Thank you.
Thank you. Good afternoon. So this afternoon, I'll be taking you through the neoadjuvant platinum chemotherapy in triple-negative breast cancer. Is it precision therapy or unnecessary risk? So this will be our outline. We'll go through the introduction, glance through the current guidelines, the evidence that support the current guidelines, go through patient selection criteria, then we will conclude. So triple-negative breast cancer accounts for 15 to 20% of all breast cancer globally. But in Africa, the narratives are a little bit different. It's about 2 to 3 times of the global rates. We all know that triple-negative breast cancer is quite aggressive and is associated with high risk of recurrence. But unfortunately, we don't have a lot of targeted therapies for triple-negative breast cancers. In view of that, there have been ways to optimize care by incorporating more chemotherapy into our treatment regimen. And one of those such process was the introduction of platinum-based chemotherapy in the neoadjuvant setting. The idea was to try and achieve pathological complete response, which we know translates into improved overall survival benefits for patients. So if you go through the NCCN guidelines, as said by a previous speaker, BRCA1 and 2 testing is quite important, especially when it comes to triple-negative breast cancer. Because when you're managing every patient with triple-negative breast cancer, you have to ensure that at least you do those testing because it's play a major role in terms of tumor response and decision-making. And from the NCCN guideline, for any patient who has a clinical T1C to T4 disease, or any patient who has an N disease and positive N node, clinical N node, you can consider carboplatin for them. If it's less than T1C, you can just do carboplatin. But if it's more than T1C, for patients who are PD-L1 positive, depending on or express PD-L1, you can consider adding pembrolizumab to their treatment. And this evidence per NCCN, per the ISMO guidelines, is a category 1 evidence A. Likewise, if we go to the NCCN guidelines, it also talk about at least giving dose dens for patients who have triple-negative breast cancer. But for high-risk patients, which define as stage 2 or 3 disease, you can introduce carboplatin in the neoadjuvant setting and can be added to pembrolizumab depending on the extent of disease. So, and this one is also a category 1 evidence. So you know that at least for most of the major guidelines, carboplatin in the neoadjuvant setting is recommended. So what support these guidelines? There have been a lot of meta-analysis that have looked at the use of platinum-based chemotherapy in the neoadjuvant settings, and most of them, their outcome was the same. One of such guidelines was from Poggio et al., who looked at systemic review and meta-analysis of platinum-based neoadjuvant chemotherapy in triple-negative breast cancers. So from their study, they were about nine studies were involved in their analysis. Then most of them 9 studies, majority of them to start with were phase 2 trials. It was just 2 trials, the GEPA-OCTO GBG84 and the Brightness trial that were phase 3 trials. Most of the other trials were phase 2. Because of that, there was a lot of heterogeneity in terms of the chemotherapy regimen that were used. Only 3 of these trials actually used the standard chemotherapy that we use. That's either atracycline-based chemotherapy followed by taxane or taxane in the reverse order. So these were some of the challenges from their analysis. And in their analysis, they noticed that if you give platinum-based chemotherapy, the probability of achieving pathological complete response was about 52%, because if you look at it from the first plot, most of the trials at least were in favor of the platinum-based chemotherapy, with the exception of the GCAM and the GEPA-OCTO trial. Most of them were in favor of the platinum-based chemotherapy. And the risk of the probability of developing pathological complete response with the addition of platinum-based chemotherapy was about 52.1%. compared to 37% in those who were in the control arm who didn't receive any platinum base. So this from the overall, at least it gives some promise that giving platinum-based chemotherapy is quite beneficial. When they looked at patients who received the standard chemotherapy, that's the anthracycline-based followed by taxane or the vice versa, they noticed that apart from the CALD-B 40603 Alliance study, which didn't really, it didn't show much of a benefit. All other studies show some benefits. And the overall, when they looked at given the platinum-based chemotherapy neoadjuvant using the standard chemotherapy, those who had the platinum-based chemotherapy had a 54.9% risk of probability of pathological complete response compared to 33.3% in the control arm. So even if you bring it down to a standard treatment guide or standard treatment guidelines of those who receive the standard chemotherapy, adding platinum-based chemotherapy was also quite beneficial. As we've talked about earlier, there's been a need for us to be doing BRCA testing. And BRCA testing, apart from all that have been said, one thing that also, one important thing is it also lets you know whether patient may respond to some treatment or not. And one of that certain is chemotherapy, because patients who are BRCA mutated are quite sensitive to chemotherapy. From the trial, just 2 trials actually looked at the response in BRCA mutated and BRCA non-mutated patients. And from those 2 trials, all of them concluded on one thing. If a patient has a BRCA mutation, those patients don't benefit from platinum. The response to standard chemotherapy arm and the response to the platinum arm were basically the same. Because in the standard arm, the response to the probability of developing pathological complete response was around 54.3%. But those who received platinum was 58%, which wasn't much of a significance. So if patient has BRCA mutation, you can do without the platinum-based chemotherapy. But when they analyzed for patients who were not BRCA mutated, those are the people who they know that had the best benefits because majority of them had a good response to the platinum-based chemotherapy. About 57% of them had pathological complete response when they received platinum chemotherapy. And those who were in the control arm or who didn't receive platinum-based chemotherapy, the probability of developing pathological complete response was about 32.7%. So from this study, we got to know that at least giving platinum-based chemotherapy is associated with between 52 to 57% probability of developing pathological complete response compared to those in the control arm who don't receive platinum-based chemotherapy. We have about 32 to 37% risk of pathological complete response. Even though we've been talking about pathological complete response, and we know that at least from NSABP trial, we know that most of once you have pathological complete response, it translates to overall survival benefits. But for this analysis, when they analyze the phase 3 trials, the overall survival for all patients, for those who had pathological and non-pathological complete response, they noted that there was no difference between patients who had the platinum-based chemotherapy and the control arm, meaning that the benefit for adding platinum-based chemotherapy is for just patients who have pathological complete response. If you don't have pathological complete response, you are not going to have any survival benefits. So this should be something that should guide us when we are managing patients, because sometimes you shouldn't wait for the patient to finish all treatment and when you know that the disease is not responding to. If there's a need for you to go off maybe the platinum base because you see that patient is not really having much response, it's always best because sometimes giving the medication it doesn't come easy. It comes with its own toxicity. We will look at in the next slide. When they analyze the toxicity profile for these patients, they noticed that majority of the time, neutropenia, grade 3 and 4 neutropenia was a very big thing when it comes to patients who receive platinum-based chemotherapy. Almost half of them were having grade 3 and 4 neutropenia. And it's worrying because most of these studies give patients granulocyte colony-stimulated factors to stimulate their neutrophils. So even if on that they are getting grade 3 and 4 neutropenia, then it's something that we, in this part of the world, we need to really look closely because sometimes most of our patients, majority of them don't really get granulocyte colony-stimulating factor routinely. And some of them may probably will come for treatment, develop febrile neutropenia. It's managed by facilities that doesn't even know what febrile neutropenia is. So sometimes a lot of patients actually may even die without us knowing. So when you're giving the medication, even though it has some benefits, we should always think about this. And if you go through most of these studies, one thing that also came up was majority of the time, there was a lot of dose adjustments or breaking treatment because of side effects in the platinum arms. So we should always be thinking about this when we are making decisions to add platinum chemotherapy to our patient. Because even if you look at anemia, majority of the patients who had grade 3 and 4 anemia were in the platinum arm compared to the control arm. And another thing that this study didn't really show up was the fact that majority of them use carboplatin. But in our system, sometimes because of costs, we substitute, they use carboplatin, but we substitute carboplatin with cisplatin. And we also know that the cisplatin tends to have a lot of nephrotoxic effects. So sometimes it adds extra cost. Patient even going to see the nephrologist may take a while or may probably will delay. And some of them tend to have long-term renal failure. So when we are doing or we are giving patient all this treatment, we need to consider this. So if you want to give a patient a platinum-based chemotherapy in the neoadvanced setting, I think the best thing is one, you should probably select your patient very well. So one, you should probably consider maybe a patient who is quite younger, who may probably will be able to take your treatment with less side effect, because neutropenia increases with age. So an elderly patient who has triple negative, you should be quite cautious not to give the patient platinum-based. As have been stated, most of the studies show the benefits in stage 2 and 3. So you should probably look at patients who have stage 2 and 3 disease. But the thing is, majority of the studies that have been done had about less than 20% of patients having a T4 or N2 disease, which is quite common in our environment, because in our environment, you have a lot of patients coming with
1 minute, doctor. You have 1 minute now. Thank you.
Coming with a lot of, say, T3, T4 or an N2 disease. So we should always think about it when you're giving. And as mentioned, patients who are not BRCA mutated are the one that benefits. So we should always consider doing genetic testing, if possible, before we start on platinum-based chemotherapy. And always consider the socio-economic factors, because where the patient comes from, the nearest hospital they can get treatment in case they have neutropenia, and also the nutrition aspect or the risk of developing neutropenia. You should consider that when you are making decisions. So for the future consideration, as I mentioned, genetic testing is quite beneficial, and we should balance benefit with potential side effects. So as established, platinum-based chemotherapy apart from but is not universally beneficial. So you should be able to select your patient very well, and also monitor your patient whilst on treatment to be able to know which patient are likely going to develop pathological complete response, and those who are not going to respond that much. And in our environment, we should have research so that we'll be able to see whether all these things are being done, whether it really applies to it. Because sometimes, based on 1 or 2 experience, most patients don't even achieve that pathological complete response that have been shown in most of the researches. So we should also be doing our own research to show that benefits in our environment. Thank you.
Thank you very much, Dr. Marvin. Thank you for this nice talk. The next speaker is Dr. Abu Dao from Burkina Faso. He is a radiation therapist, and he did a lot of things in implementing practices and machines, radiotherapy units in Francophone countries like in Congo, in Burkina Faso. He's a great lecturer in his field. And his communication will focus on radiation therapy and breast conserving surgery. Dr. Dao, you have 10 minutes to deliver your talk. Thank you very much.
Okay. Can you help me to share my screen? Okay. It's my screen. Are you able to see my screen? Yes.
Not yet.
Okay.
Not yet. Okay.
Is it okay now?
Yeah, it's okay. You just have to do full screen.
Okay.
Yeah, it's okay now. Thank you. Go ahead.
Okay, thank you, everyone. Good afternoon. Radiotherapy to increase the conservative treatment of breast cancer in West Africa. Let me. So this title is a provocating title if surgeon and medical oncologists are online. However, this is close to the truth because conservative is difficult without the addition of radiotherapy. It is clear now we need to find a way to reduce, stop breast mutilation. My name is Dr. Abu. I'm a senior radiologist from Health Invest Africa Partners. My topic, the content of my topic is contain introduction. We can say that breast cancer is the most common cancer in West Africa, with more than 53,000 new cases in 2022, according to GlobalCan. And regarding the Global Can reported 10,901 deaths in 2022. A clinical review, breast cancer is local, regional, and systemic disease. As soon as the disease perforates the basal membrane, it diffuses fastly throughout the body, especially through the lymphatic network, involve the regional lymph node and later distant organs. The treatment includes local regional treatment regarding surgery and radiotherapy, and systemic treatment regarding chemotherapy, immunotherapy, targeted therapy, and endocrine therapy. Indication of breast conservative surgery. There is no breast conservative surgery if the patient cannot get radiotherapy. Now, what is the foundation for conservative treatment? What is the statement of conservative treatment in West Africa, and what is the availability of radiotherapy in West Africa? The interest of our topic is to highlight the role of therapy in breast conservative treatment. Regarding international recommendation for breast conservative treatment, we didn't find definition, but we can say that breast conservative treatment is a conservative surgery. The surgeon will conserve the breast gland where there is no disease. And this surgery will be followed by radiotherapy, adjuvant radiotherapy in the whole breast, or without regional lymph node, or without boost. And the treatment can also be completed by systemic treatment regarding the features. Breast conservation surgery followed by radiotherapy has become this stage breast cancer, and for ductal carcinoma in situ. In this publication, Early Breast Cancer Trialists Cooperative Group published this paper in 2005, and we can find many publications in literature which show equivalent disease-free survival, distant disease-free survival, and overall survival in women undergoing breast conservation surgery with irradiation compared to radiotherapy. Now, since 48 old, the researcher tried to know if we can conserve breast and get the same up when we remove all the breast. And many trials find that it's possible to conserve the breast, give radiotherapy, and we can get the same outcome. The guideline we follow in our centers is the National Comprehensive Cancer Network. In 2024, the recommendation to have breast conservative is to give radiotherapy in the whole breast cancer, even if you have negative axillary lymph nodes, 1 or 2 positive lymph nodes, or more than 4 positive lymph nodes. Now there is a controversial regarding the patient with the age more than 70 years with the hormonal receptor positive HER2. For NCCN, they recommend you can omit this radiotherapy, adjuvant radiotherapy for this kind of patient. Now, for ductal carcinoma in situ, the NCCN recommend radiotherapy after breast conservative, but some recommendation say that we can omit radiotherapy for this kind of cancer. In our center, we give radiotherapy. What about the breast conservative treatment in West Africa? We find many publications in the literature, but we want to talk about outcome published by Van der Pue and collaborator. They find that we have more than 70% of patients treated in Africa, in Nigeria, which have advanced stage breast cancer. It's clear that patient cannot get conservative surgery because the cancer is very high. The stage is high. In Ivory Coast, in 2021, ACA and collaborator 15% of patients receive conservative surgery. And for radiotherapy, only 13% have received radiotherapy. The patients who get conservative surgery. Now, what is treatment? It is now it is clear that access to radiation facilities in Africa is a major factor contributing to limited access to conservative breast surgery. Now, even where facilities are available in Africa, very few men candidates for breast conservative treatment, despite achieving good response rate to no adjuvant chemotherapy. This kind of patient is a patient with T3 disease. Now, what about the therapy in West Africa? We have in Africa, this publication is from EIA, and we see that in West Africa, there is one machine for per million of people. And when we check this table, in Middle Africa, which includes Africa, you have many countries, we have less centers in Africa, in Middle Africa than North Africa and South Africa. And regarding the machine, we have 88 machines in Middle Africa, and in North Africa, we have 237, and in Southern Africa, we have 107. And the population in Middle Africa is more than billion. Now, we try to, many countries in West Africa have no radiotherapy center. In blue color, we see that it is one center in everywhere, and you have 3 centers in Ghana, 4 centers in Mauritania, and 9 machines in Ivory in Nigeria. Now, we try to use the publication of Niloy to know how many machines we need in West Africa. And we find in Africa, we need 585 machines, but when we count the number of machines in West Africa, is only 30 machines. So it means we need more machines. We take area, need 284 machines, but Nigeria have 9 machines. So what suggestion we can do is to say that drug out with the International Atomic Agency, some collaborators like Medilink, Onco, Health Investment, they try to help many countries to establish new or to upgrade equipment. And the new technique can also help reduce the treatment time from 6 weeks to 3 weeks or less. Conclusion, therapy is an essential therapeutic method for breast conservative treatment. West African region on the margin of the progress recorded in realization of radiotherapy, expanding facilities is a major step to breast conservative treatment, and the advanced techniques such as MRT and arc therapy can help to reduce the treatment time and increase the number of. If we want to stop breast mutilation, we need more radiotherapy resources in West Africa. Thank you.
Thank you very much.
Thank you. Yeah, go ahead, Dr. Isaac. Thank you very much.
Yeah, thank you very much, Dr. Dow. That was an excellent talk. And we are gradually rounding up the talk to I'll be having the last speaker. Thank you for joining and staying till the end. The last speaker is Dr. Lalekan Olasende. He will be talking on de-escalating breast and axillary surgery in West Africa, challenges, prospect, and opportunity. And I think that topic dwelled very well with the previous speaker who is talking about frequent mutilation of breasts, of women breasts in Africa. I'm sure with the next speaker, we'll be able to see how much mutilation we are doing and how we can stop this mutilation. Dr. Lalekan Olasende, please go ahead and have your talk.
Okay, thank you very much, Professor Olache. I say good afternoon to everybody.
Please put your slide on slideshow, please.
It's already on slideshow.
Not on our side.
Okay. Okay.
Probably you stop sharing and you will share again.
Okay. Okay. Are my slides visible now?
Yeah, we can see your slide, but it's not on full screen.
Maybe click on from current slide. Presentation view.
Okay. All right. Can you see my slides now, please?
We can see your slide, but it's not on full screen.
It's supposed to be. How about now, please?
Not yet on my side.
It's on slideshow at my end.
We are seeing a lot of things on your screen, speed, sound, and all those things. That's what we are seeing here. Why not click the presentation view?
That's where I've been. I've been on presentation view, and
if you double click on the slide, will it open up?
Do you get that? Double click on the slide.
yeah, I've done that.
Because of our time, we need to move on.
Okay, can I just go ahead, please? I think I've done that a couple of times.
Okay. But we can't see the slide. We are not seeing
Yes,
the slide.
I'm just trying one more time. Okay. So, good afternoon, everybody. I will be talking very briefly on de-escalating breast and axillary surgery in West Africa. I will be talking about the challenges and also make recommendations. As I did mention earlier, the last speaker laid a very nice background on what I am going to talk about. And that's with respect to the need for breast conservation in the West African sub-region. Just as a form of background, it's clear that breast surgery is a prototype of a specialty that has undergone major refinements over the last couple of years, from a very radical approach to its treatment to a more conservative approach, right from the very early trials, the NSABP06, that showed equivalent outcomes following radical mastectomy and lumpectomy with radiotherapy. There has been major refinements over the last couple of years to decades. And currently, it's no longer patients who present with early stage disease alone who do benefit from breast conserving surgery, but also patients who present with a locally advanced disease who get downstaged after having received neoadjuvant chemotherapy. And that's the current state of breast surgery as of today. And not only do we have this experience with respect to the management of the breast itself, a similar pattern is also observed with respect to the management of the axilla. Right from the NSABP32 trial that showed equivalent outcomes following axillary lymph node dissection and sentinel lymph node biopsy for patients who are node negative, down to the Z11 and Amaros trial that even showed that even in patients with limited disease in the axilla, much less can still be done. And currently, we know that even for patients who present with node positive disease, who become downstage to becoming node negative after having received neoadjuvant chemotherapy, according to the SNF-NAC Sentinel trials and the Akuzoxi 1071 trials. Such patients can also be offered sentinel lymph node biopsy without compromising oncologic outcomes. The question we're going to ask is, why do we need to do less in the axilla? What is obvious is that patients who have their breasts conserved certainly do have better quality of life relative to those
It's
who
like
have
your
had.
slide is not moving on our side. It's only what we see, challenges of a de-escalation. Is it moving? Okay, you move to the next now.
Okay, so what seems to be obvious is are the psychosocial benefits of breast conservation, of course, which includes better quality of life, psychosocial health, better perception of body image by the patients, and a host of other benefits. What is perhaps not very obvious is the fact that breast conservation actually does not only improve quality of life, it also saves lives. And we found this out from, a study which was carried out in Nigeria amongst patients, young patients who have had mastectomy, in order to understand their experiences. And what we did observe was the fact that their fear of mastectomy did contribute to early disclosure of their disease condition, and subsequently also affected the early commencement of treatment. And other studies have clearly shown that the fear of mastectomy is one of the major disincentives to early presentation amongst patients. So what we see clearly, therefore, is the fact that any drive towards breast conservation does not only improve the quality of life of patients, it also, in a way, promotes early presentation, which is, as we do know, one of the major challenges that we have in the subcontinent. The same story holds for the axilla. When patients undergo axillary lymph node dissection, we our focus is often usually on extirpating, all of the disease and ensuring that we cure the patient. But what we often do not consider is the fact that axillary lymph node dissection is often attended by a variety of complications, notably lymphedema, which can be very severe and debilitating in some instances. We reviewed a cohort of Nigerian patients who at different time points. First, we evaluated patients who were presenting prior to commencement of treatment just to determine the baseline prevalence of lymphedema. And we found that as high as 12 to 14% of patients before having received treatment already had lymphedema. And when we looked at patients who have had surgery, a cohort of breast cancer survivors, we found out that lymphedema rate was as high as 25 to 40% when we used different metrics to determine the presence of lymphedema. So when you consider the fact that more than a quarter of patients to about a third of patients who have had breast cancer axillary lymph node dissection plus or minus radiotherapy would develop lymphedema, you would agree with me that these figures are staggering, and there's a need for us to constantly think about de-escalating surgery, not only in the breast, but also in the axilla. So summarily, we would see clearly that de-escalating surgery, both in the breast and the axilla, will improve quality of life, has the potential of actually saving lives by encouraging women to present early because they know they're not going to lose their breast. And what's very important to note, particularly in the sub-region, is the fact that the majority of women who are affected are relatively young in their reproductive period, and undergoing mastectomy at such a period is likely to leave them quite devastated. And we also do know that de-escalating axillary surgery has a potential of improving their quality of life by significantly reducing lymphedema rates. Now, what are the challenges of de-escalation or de-escalating breast and axillary surgery with the West African subcontinent? Obviously, you would all agree with me that patient eligibility is a major challenge. Patients, de-escalation can be considered upfront or after systemic therapy. Now, the majority of Nigerian patients and in the West African sub-region, the story is also similar. Present in advanced stages. In most series, 60 to 80% of patients would present with stage 3 or stage 4 disease. Barely 20 to 30% in most series would present with early stage disease. And that goes to show that the majority of our patients are ineligible for upfront breast conservation. Another challenge that we do observe is the limitation posed by radiotherapy services. And that's why I really quite appreciate the last speaker who spoke extensively about the importance of radiotherapy services in achieving breast conservation. This is so key. It's a compulsory adjunct to breast conservation, without which recurrent rates is likely to be abysmal and might also likely impact or certainly would impact on survival. Now, we also do observe that lack of multidisciplinary team meetings in many institutions is a drawback to achieving breast conservation. Breast conservation, called breast conserving surgery or surgical de-escalation in breast cancer management, is not something that can be achieved by just a single physician. It requires multidisciplinary collaboration amongst various specialists, surgeons, radiologists, pathologists, clinical oncologists are all needed in taking decisions to de-escalate breast cancer surgery. But in many institutions across the sub-region, MDTs are not very well developed, and this does contribute to the challenge of having low rates of de-escalation in the subcontinent. We conducted a national survey which did show that clinicians who do not participate regularly in MDTs were not likely to adopt contemporary treatment modalities in the management of their patient. We also do know that there are infrastructural limitations which can hinder de-escalation. Proper de-escalation would require things such as clip placement for proper localization of tumors, particularly when patients present with non-palpable tumors or screen-detected tumors, or patients respond after neoadjuvant chemotherapy, and you need a way to localize the lesion. So proper, localization is key, and this requires services of radiologists who will be needed to place clips and also to wire localize the lesion prior to excision. When these services are not available, it limits the ability to accurately de-escalate breast and even axillary surgery in many instances. Of course, this is particularly important with respect to axillary de-escalation. That's the issue of limited access to radioisotope. Now, for patients who undergo sentinel lymph node biopsy upfront, those are patients who present with no negative disease. Sentinel lymph node biopsy can be conveniently carried out with blue dye alone with accurate results. However, for patients who present with node-positive disease who require neoadjuvant chemotherapy before becoming node negative, performing sentinel lymph node biopsy with blue dye alone will not give accurate results. That is a false negative rate of at least 10%, which is what is considered as accurate results. From the SNF-NAC trial, Sentinel trial, it's clearly shown that for you to accurately stage the axilla in the neoadjuvant setting, you need at least dual tracers. You need radioisotope with a blue dye. You also need to have taken out at least 3 nodes, and ideally you should include the marked node or clip node as part of your sentinel nodes to improve your accuracy. Now, in the West Africa sub-region, just similar to radiotherapy, radioisotope or nuclear services is not it's not very much available. It's sparsely available in most institutions, and this kind of limits our ability to adequately de-escalate patients in the neoadjuvant context. So what are the possible recommendations or ways to overcome these challenges? This will be my second to the last slide. First, we need to improve on awareness and advocacy. The more we get patients who present early, the higher our chances of achieving upfront de-escalation. And this is very important. In our most recent review, over the last 5 to 6 years, we've been involved in extensive community awareness, and we did observe a significant drop in the proportion of metastatic disease. In the initial 5 years of our review, we observed that metastatic disease accounted for about 23% of our patients, and that dropped by more than 10% over the last 5 years of increased advocacy. So there's a lot to gain by community awareness and advocacy. Increased use of neoadjuvant chemotherapy has huge potentials of improving our ability to de-escalate. Patients who present with locally advanced disease are the most prevalent, and if we are going to increase the rates of de-escalation, we need to improve on our use of neoadjuvant chemotherapy in order to downstage these patients and then get them eligible for breast or axillary de-escalation. We need more multidisciplinary team meetings. We need, of course, to increase advocacy for investment in radiotherapy services. In the Nigerian context, more private players are beginning to get involved in provision of radiotherapy services, and this has significantly improved the outlook. Of course, we need to improve radiology services, particularly with respect to localization. And we need pragmatic solutions. And I'm going to share one or two of such pragmatic solutions that we have adopted in our practice. One of them is with respect to the use of spinal needles. Fortunately, we have from time to time supplies of clips and wires and all of that for localization. But from time to time, we run out of these supplies. And part of the pragmatic solutions that we've adopted is the use of spinal needles, right, to drive in clips. We also use clips such as laparoscopic clips, like titanium clips, that we can use in place of the conventional clips, and we have found them to be useful and effective in our practice. Another pragmatic solution that we have adopted is with the use of conventional X-rays for specimen imaging. An important component of breast conserving surgery or axillary de-escalation is specimen radiology. Now, we do not have X-ray machines in the operating room, so what we do is to get specimens taken to radiology, which is just a minute away from the operating room and then get the specimen imaged so that we're sure that we correctly took out the specimen. Not the ideal, but it's getting the job done. One other pragmatic solution, which is going to be my last bit here, is looking at how to overcome the challenge of lack of radioisotope. Do not have radioisotope, but presently we're carrying out a trial that is a pragmatic trial that is looking at combining axillary ultrasound with blue dye in the neoadjuvant setting amongst patients who convert from being node positive to node negative after neoadjuvant chemotherapy. That trial is still on. We have so far enrolled 53 patients who are node positive. 32 of them were confirmed to be pathologically node positive. And then of those who have completed neoadjuvant chemotherapy, 8 of them converted from being N1 to N0 and went ahead to undergo sentinel lymph node biopsy. For the purpose of this trial, every patient who gets sentinel lymph node biopsy, we still go ahead, to have axillary lymph node dissection so that we can have a way to determine if the accuracy of our sentinel lymph node biopsy. Like I said, the trial is still on. It's just a picture showing sentinel lymph node biopsy being performed. In conclusion, I would say that there's a need for us to promote a drive towards de-escalation of breast and axillary surgery in West Africa. Despite the challenges which are obvious, we believe that de-escalation is feasible without compromising safety, particularly when we adopt pragmatic options, and we know that de-escalation will not only save a woman from being mutilated, it also has the potential of saving lives. I will end with this quote. It's an article that I just saw a few days ago, and that quote really caught my attention. This was a quote from a patient in that trial. It says, "How will I live this life that I am trying to save?" A lot of times as clinicians, we're engrossed in saving the life of the patient without considering the quality of life of the patient. All of these have to go hand in glove. Thank you.
Thank you very much, Dr. Olalekan Olasende, a surgeon from Nigeria. That is the last slide for today and last presentation for today. And we will go ahead with question and answer. If you have any questions, I know there's one question that I saw on the chat box by Tina Davis, who is asking if there is a radiotherapy machine in Sierra Leone. Dr. Dow, I think the question is directed to you, that do they have radiotherapy machine in Sierra Leone? And how many are they, if you are aware?
No, in the EIA, I didn't machine in Sierra Leone. Okay. When I build my figure, I forget to add Sierra Leone in the figure, but there is no machine in Sierra Leone. But now I don't know. Sometimes you have a country, the country can get the machine, but didn't send the report but in the EIA, there is database, there is no machine in Sierra Leone.
Thank you very much. If you have any other question for the first speaker, second speaker, and the third speaker and the fourth speaker, kindly, you can quickly unmute yourself and ask your questions. We just have about 5 minutes because we are far beyond the time slot allotted for this presentation. I can't see any other question on the chats. So let me ask Dr. Olalekan Olasende, what's your experience so far from those in those patients that you did the escalation of the axillary surgery? What's the report you are getting from your pathology for the 8 patients that you've operated, comparing your sentinel lymph node biopsy compared to the axillary dissection? Any difference? Are you getting any? What's the response they are providing you?
Yeah, thank you very much, Prof. So first, I would say that in all the 8 cases, sentinel lymph node biopsy was successfully completed. in all of them. The average number of nodes we were able to harvest was in the range of 3 to 5 in all of the cases. I would also say that in all but one case, we were able to include the clipped node in the Sentinel node, which is pretty good for us. And as I did mention earlier, inclusion of the clipped node, that's the node that was initially biopsied and clipped pre-chemotherapy. If it's included in your sentinel lymph node biopsy, it does significantly improve your accuracy. So we've been able to achieve that in nearly all but one of the cases. With respect to concordance, just looking at the data from 1,000 feet, we have not done in-depth analysis, but we have been able to find what looks like pretty good accuracy just from the sentinel lymph node biopsy alone. There have been concordance in 6 of the 8 cases, meaning that in patients in whom the sentinel lymph node biopsy says there is no tumor, axillary lymph node dissection also did not find any tumor. And in patients that the sentinel lymph node biopsy says there is residual disease, the axillary lymph node dissection specimen also did show the same. So looking at that, and we should keep in mind the fact that the objective of this study was not just to look at blue dye alone. We're going to compare that with preoperative ultrasound in our analysis. So by the time we're getting that just from blue dye alone, it does look promising, but not to be too preemptive. We'll wait until we get the final results. But so far, it's been so good.
Yeah, Dr. Marvins, the question is for you. In Africa, there's no enough provision for patients to do genetic analysis. You have said that platinum-based regimen is good for patients that are BRCA negative. Aside from patients that are BRCA negative, how can a surgeon or an oncologist working in West Africa select patients that will benefit, aside from triple negative patients that should benefit from platinum-based therapy? Or should they just place all the patients on platinum, knowing that there are still some there are side effects that is associated with deployment of this approach? Please go ahead.
Okay, thanks for the question. So the standard is to do your BRCA testing. If because of limitation, it cannot be done, as I mentioned, sometimes even if BRCA, you are doing your BRCA testing, also depend on monitoring your patients regularly. Because if you notice your patient probably is not responding to the treatment, it's best you stop, because ideally if you have the patient is BRCA negative, you know the person was from BRCA mutated, the person is not going to respond. So if you don't have the test available, it's about regular monitoring of your patient after every cycle. Examine the patient to see whether the patient is responding. If after 2 or 3 cycles, the tumor is just as it is, so it's probably not responding, you can then decide that likely patient is not going to respond to your platinum-based chemotherapy. So you withhold that. But with time, you look forward to be able to just get genetic testing. That will be the step in the right direction. You'll be able to get a genetic testing in your country so that at least as much as patients that can afford will be able to have the BRCA mutation testing done before they start on platinum-based chemotherapy. Thank you.
Thank you. Dr. Fumilola Wurola, please, may I ask you, 70% of your patients are BRCA positive, which seems to be higher than what has been reported in Africa, though it was said that BRCA positivity is quite high in Nigeria and some other West African country, but you are talking of 17%. What do you think, what will you advise as physician managing breast cancer vis-a-vis the desire to look for this BRCA positivity in our patients so as to be able to appropriately manage our patients?
Yeah, thank you, sir. I think it will be good for, if it's up to me, I will say all patients that present to us with breast cancer should be tested, at least for BRCA1 and 2 gene. But if you are not going to be tested, just like in this study, we are testing people that are 60 years and below, I think it will be good. Out of the 12 patients that are positive now, only 1 person is above 50. So that shows that testing a younger people will give you the desired result, and that might be a good thing to go by. And also, just like our data, majority of them are triple negative, but we have few people that are ARP are positive, 2 of them, every other person are triple negative. So it further shows that even if we have restrictions or constraints with resources, we should prioritize younger women, we should prioritize triple negative patients. But most importantly, a way that we can screen for everybody going forward, I think that will help us.
I think I agree with you that one of the things AORTIC West Africa should work on is to see how we can establish a facility to screen BRCA in West Africa. And we'll liaise with the mothers, the AORTIC International, and see how collaborators can help us to do this. From this data, it's obvious it's something that we need to begin to look at and see how we can screen almost all our patients for BRCA positivity. I want to thank all the speakers. I don't know if Dr. Sidika is still on. I want to, if it's on, he will have the last word. Well, I want to thank every speaker that has spoken today and my co-moderator, Dr. Sidika. In West Africa, we are trying to look for opportunity to continue to educate ourselves using all available opportunity. Next month, I'm told, is a prostate awareness month. We'll see if we will be able to organize something around prostate cancer to commemorate the prostate awareness month. Till then, I want to encourage as many that are not members of AORTIC to please join us. There are quite a number of things we can do together. And by joining us, we'll be able to work as a team to build the AORTIC and also to build the capacity in the area of management of cancer in West Africa and in the world, essentially. We can benefit from the North America, East America, Europe and all that, and take all the advantage that AORTIC has involved. Aside from North-South collaboration, there are a number of countries that have facilities that we can benefit from, and working together as a team will help us to galvanize this. From the Secretariat, I don't know if you have any announcements.
Thank you. I will invite everybody to our event next year, of course.
Yeah. The next AORTIC meeting is holding in Tunisia. As you can see, please kindly, the registration will open probably the next few weeks. Kindly log on and join us and prepare to attend the meeting. It's promises to be great. Till next time that we'll meet, I want to thank everybody that joined and have a wonderful day.